Next up, we have a rheumatology case discussion by Dr. Mithun CB sir. He did his MBBS from Government College Thrissur, his MD from Government College Trivandrum, and his DM in clinical immunology and rheumatology from JIPMA Pondicherry. His areas of interest include SLE, rheumatoid arthritis, spondyloarthropathies, psoriatic arthritis, and primary immunodeficiency. He has numerous publications in both national and international journals. The presentee will be Dr. Namita, who is a final year resident in Department of General Medicine at AMRITA Institute of Medical Sciences. Welcome you, sir.
Welcome to the PG discussion by the AMRITA Medicine Update. And here in our PG discussion case, we will be discussing a multi-system case. A multi-system case is a real challenge to the physicians, as the diagnosis can be diverse and it can include malignancy, infections, and autoimmune diseases. Therefore, to arrive at a correct diagnosis is the first and the most important thing in this type of multi-system cases, because only if you arrive at a proper diagnosis, then only you can start the correct treatment. A proper diagnosis at a correct time can save a patient's life. In this case discussion, Dr. Namita will be. Dr. Namita is the final year medicine resident in the AMRITA Institute of Medical Science, General Medicine Department. She will be discussing the case. Over to you, Dr. Namita.
Thank you, sir. I'm Dr. Namita, General Medicine final year resident. So I'll be discussing a case discussion based on a rheumatology or multi-system involvement. So moving on to the case. Patient is a 47-year-old female hailing from Idukki. She's a housewife by profession, and the informant is the patient and her daughter. She presented with complaints of multiple joint pains of 2-year duration, which got aggravated since the past 2 months. And she also complains of tingling and numbness of both upper limbs and numbness over the lower limbs of 2 years duration, which got aggravated recently for the past 2 months. And also she complains of redness of the right eye since 2 months, which got aggravated for the past 2 weeks, along with fever 1 month duration and decreased hearing on the right ear 1 month duration. So moving on to the presenting complaint in detail. So patient noticed pain involving both shoulder, elbow, wrist and small joints of the hand, along with both knees and ankles since 2 years. Initially, she recollected the history that the pain was mainly over the large joints, which started with bilateral shoulder and elbow, along with knee and wrist. Later, she also noticed that pain was present over the small joints also. Coming to the nature of the pain was episodic in nature and noticed more during the morning hours, associated with early morning stiffness, which is lasting for more than 30 minutes. And she also recollects that the pain got relieved with analgesics to some extent. Then for the last 2 months, she had worsening of pain and swelling of the bilateral knee, shoulder, elbow and wrist, associated with redness also. And because of this thing, she was not able to carry out her daily activities. She also noticed that the duration of the early morning stiffness was also increased over the last 2 months. And upon continuing the activity, she got some relief. There is no history of migratory joint pains. Then coming to the next symptom, she also noticed that there is... Yes, sir.
Shall I interrupt here?
Yes, sir.
I think we will discuss this joint pain, then we'll move ahead.
Okay, sir.
And after getting the history of the joint pain, what do you feel?
So it is involving both large and small joints. So it is a polyarticular origin, and it is also more in favor of an inflammatory pain. Because
why you are saying that it's an inflammatory pain, and how will you differentiate a joint pain from a non-inflammatory joint pain?
So usually inflammatory pain will be associated with early morning stiffness, and then it will get relieved to some extent with activity, and also some constitutional symptoms would be present in case of inflammatory pain. But in case of non-inflammatory pain, they'll be feeling better like while doing rest and all. So those things are present in my patient.
The early morning stiffness is the most crucial in this history, because if early morning stiffness lasting 30 minutes suggests that patient is likely having a inflammatory pathology leading to the joint pain.
Okay.
And can you tell me some examples of inflammatory joint pain?
Inflammatory joint pain, it can be monoarticular, oligoarticular or polyarticular. So monoarticular pains can be either infections, like any infections, especially gonococcal, Lyme's disease, those kind of infections can causes monoarticular pain. Then trauma, gout, all those things can be caused by monoarticular pain. Coming to polyarticular or oligoarticular, it can be either due to sepsis, but infections like gonococcal infections, Lyme's, Mycobacterium tuberculosis, and other non-infectious etiologies like connective tissue disorders, vasculitis, then rheumatoid arthritis. All these things will be we should consider in case of polyarticular or oligoarticular pains.
Yeah, polyarticular infection is less likely, except the reactive arthritis can have polyarthritic involvement. Otherwise, inflammatory polyarthritis, usually it is autoimmune or connective tissue related diseases like rheumatoid arthritis, psoriatic arthritis, SLE, like that. Whereas if you are dealing with a monoarthritis, the infection should be your first differential. And the second differential include the crystal arthropathies like gout. Okay. Then you told patient has a small and large joint involvement. Can you tell me some diseases which can have both the or predominantly large joint involvement?
Osteoarthritis, all those things can be predominantly large joint.
Yes. And if there is a both large and small joints are involved, and you're saying this is inflammatory condition, it's likely a polyarthritis, inflammatory polyarthritis, involving the large and small joints. And you also told the pain is episodic in nature. What are the differentials of episodic joint pain?
Again, sir, inflammatory arthritis secondary to connective tissue disorders or rheumatoid arthritis and vasculitis. All those things can cause
one thing is that usually in rheumatoid arthritis, the pain is usually additive. That it is not episodic. Episodic means in between the episodes, patient will be completely asymptomatic. But there are some exceptions, like in palindromic rheumatism, it's a subtype of rheumatoid arthritis. You can get episodic joint pain. And in some conditions, autoimmune conditions like vasculitis, you can have an episodic type of arthritis. And the most common cause of episodic arthritis is the crystal arthropathy, that is the gout. Okay.
Okay.
Go to next slide.
So moving on to the next symptoms, she also noticed that there was tingling and numbness of both upper limbs along with numbness of the lower limbs. So coming to the upper limb symptomatology, she noticed that the tingling and numbness was mainly in the lateral aspect, that was also intermittent, but she was telling that all these pains got aggravated during night and while sleeping. And coming to the numbness of the lower limbs, it was mainly over the foot. There is no history of burning pains or tingling. And coming to the motor part, there is no history of any motor weakness in the form of difficulty in holding objects, buttoning or unbuttoning, writing. And coming to the lower limb, there is no history of slippage of chappals from foot with or without knowledge, no history of any gait instability, no history of any proximal muscle weakness in the form of lifting of arm above the shoulders or lifting objects or climbing stairs. So then coming to the next symptom, she also noticed that redness over the right eye along with watering, which is associated with severe pain. There is no history of any discharge from the eyes, no history of blurring of vision, double vision. With that, she consulted an ophthalmologist and given some topical applicants, following which she got some symptomatic relief. But for the last 2 weeks, she developed severe pain along with redness over right eye mainly, and no history of photophobia. And she also complained to
Namida,
Yes,
can you just review that history or just interpret that history? What could be she having?
So basically, redness over the right eye along with pain. So that is an important symptom, and there is no significant vision loss or visual impairment. So we can appreciate that there is some feature suggestive of scleritis is there.
Okay, I will ask you one question. What are the causes of red eye?
Red eye, it can be either a mild conjunctivitis from it can be vary from the like associated symptoms. Like if only a red eye with any visual impairment, it can be a conjunctivitis, scleritis, episcleritis, like that.
Usually that will not cause redness, blurring of vision. If there is blurring of vision,
Then
what
we
could be
uveitis and uveitis.
And if there is pain and red eye with pain,
Then
what could be?
scleritis we should suspect rather than episcleritis or conjunctivitis. We should stick on to that. Scleritis would be there because of the pain and tenderness.
Okay. Can severe dryness of eyes cause redness?
Yes, but there won't be any pain during that time. In keratoconjunctivitis sicca or interstitial
What
keratitis,
will be the predominant symptom
dry,
along with redness of eye?
dry eye will be there for them.
Dry eye, they usually say that there will be foreign body sensation in the eyes. Okay, then in this patient is most likely having the scleritis of right eye.
Right.
Okay.
So next symptom was fever. Fever was low grade, intermittent in nature for the past 2 months. There is no history of diurnal variation, not associated with chills or rigor, not associated with any night sweats, no history of any other localizing symptoms associated with fever, which was unrelated to joint pains also. And the next symptom was she also noticed that there is reduced clarity of sound in the right ear for the past 1 month, which was gradual in onset and non-progressive. It was associated with fullness in the right ear also. She doesn't complain of any hearing impairment in the left eye. No history of any ear discharge, nose block or trauma. No history of any intake of any drugs. No history of any tinnitus.
1 second. Do you think this history is significant, or is just a
Yes,
casual
sir.
history?
Because all the previous symptoms we got in a chronological order. So in a multi-system involvement, this also will give a diagnostic clue for our further workup.
Okay. What could be the cause for her hearing loss?
That at this point we cannot differentiate whether it is sensory neural or conductive hearing loss. After examination only, we'll be able to get some clues regarding that.
Can you tell me some differential diagnosis like arthritis with hearing loss?
So usually it is seen in vasculitis, sir. Arthritis and hearing loss. Usually it is associated with vasculitis. Usually ANCA-associated vasculitis or small vessel vasculitis. In rheumatoid arthritis, also in advanced diseases, whether it is involving the joints, in the small joints over the stapedium and all, we can get conductive hearing loss. And sensory neural also can be seen in rheumatoid arthritis also in later stages.
Rheumatoid arthritis with vasculitis, secondary vasculitis. Okay, great. Okay, what is, okay, go ahead with the next slide.
So coming to the next symptomatology, she also complains of dry cough of 2 months duration. There is no associated breathlessness, no history of orthopnea or PND, no history of any dyspeptic symptoms, no history of worsening of cough at night, no history of any sputum production. So coming to the important negative history we should consider is there is no history of epistaxis, no history suggestive of any recurrent sinusitis or chest infections, no history of hemoptysis, no history of
Dr. Namita, why you said this negative history of no epistaxis? Why it is important to say the negative history here?
Was a 47-year-old lady who presented with polyarthralgia or polyarthritis along with fever, hearing loss, dry cough. So we should think in terms of vasculitis as a possibility, especially granulomatosis with polyangiitis. In that case, the associated symptomatology will be epistaxis, hemoptysis, or recurrent sinusitis bar chest infection, sir.
And that means that if you are suspecting a disease like a vasculitis or even rheumatoid arthritis vasculitis, you should know the extent of disease or extent of involvement. That's why we are taking this negative history. Okay, we are seeing whether the other organs are affected by this vasculitis or not. Okay, next.
She also, for the last 2 months, she was having severe fatigue. So she was feeling that she was having imbalance while walking for the past 2 weeks, more towards the right side. But there is no worsening in the night time, no difficulty in walking through narrow passages or any other history of motor weakness. As I mentioned earlier, there is no history suggestive of any distal power weakness also. And coming to the other relevant history, no history of any abdominal pain, no history of altered bowel habits, no history of photosensitivity, no history of skin rash, nodules, oral ulcers or genital ulcers, no history of hematuria, frothing of urine.
Dr. Namita, why you are saying there is no history of photosensitivity, skin rash, nodule, oral ulcers, genital ulcers?
So
what is the importance of this negative history?
So first I'll tell about photosensitivity. Even though any multi-system involvement in a lady, we should consider SLE as a first diagnosis. So the first and
Not
foremost
as first, it should be in your differential.
in your differential. So we can ask for photosensitivity, and any vasculitis can present with petechiae, purpura, nodules, oral ulcers, genital ulcers, everything. So that negative history also we should be asking.
Okay. Genital ulcer, in which condition you get a genital ulcer?
Beckett's disease, it will be more in reactive arthritis, we'll get genital ulcers.
Yes, correct. And pain abdomen, altered bowel habits.
All any vasculitis like
Okay.
pan
Any GA involvement or
GA
GA vasculitis, you can get pain abdomen or altered bowel habits. Good. Okay. The hematuria part, I think you didn't mention. No?
No history of hematuria, frothing of urine, swelling of lower limbs, periorbital puffiness, or recent worsening of hypertension. Because all
this history is suggestive you are looking for a renal
involvement. So that also we have ruled out.
Okay.
Then with these symptoms, she went to a nearby hospital and told that rheumatoid factor was positive and started on medications.
Does she said that the rheumatoid factor is positive?
Yes, sir. She was.
Does he mention about the value?
She was she told that it was 120.
120. Pretty high dose,
yeah,
high value.
High titer.
Okay. What medication she was started on? Any?
Yeah, sir. She told that she was started on oral prednisolone and methotrexate.
Okay. Good.
So I'll be telling in the treatment history because her daughter is also educated, so they recollected the names and all.
Okay.
So coming to the past history, bronchial asthma, taken treatment till 8 years ago, but since then she was not on any medications and she was not getting symptoms. And she was diagnosed to have systemic hypertension 3 years ago and on medications. So coming to the personal history, sleep is normal except the pain part. That time only disturbed sleep and normal appetite, normal bowel and bladder habits. And coming to the obstetric history, P2, L2, A2, first abortion at 4 months and second abortion at 2 months. And coming to the menstrual cycle, irregular, initially having oligomenorrhea. For the past 2 months, she is having amenorrhea. So coming to the treatment history, since 2 months taking treatment from the local hospital, and she was able to tell the names. She was on prednisolone and methotrexate, and after starting the treatment, she got some relief of her symptoms also. So coming to the summary, we have a 47-year-old
summary of the history, no?
Summary of the history. So we have a 47-year-old female with past history of bronchial asthma and essential hypertension who presented with complaints of multiple joint pains of 2 years duration with recent aggravation of for the past 2 months associated with redness of right eye, hearing impairment in the right side, along with numbness over both upper and lower limbs, along with low-grade fever and dry cough of 1 month duration. So all these symptoms suggestive of a chronic symmetrical polyarthritis along with ocular, auditory and some sensory symptoms. This much only we'll be able to tell at this point of time.
Here, except the numbness, we evaluated other symptoms. How you interpret that numbness of the upper limb and lower limb?
So the upper limb, she like coming to the examination, I'll tell she looks little obese. So it can be a carpal tunnel also because all the symptoms can be suggestive of in the lateral aspect and more in the sleeping time during.
Also, it is intermittent. It is not persistent.
Not persistent.
That is also favoring a carpal tunnel syndrome. Any inflammation in the joints can, especially in the wrist joint, can lead to carpal tunnel syndrome. Therefore, it can be secondary to the inflammatory synovitis.
Okay, sir.
And it is intermittent. Therefore, it aggravated by sleep or by doing certain positions, it can aggravate. What about the lower limb numbness?
Lower limb numbness, it was bilaterally symmetrical and extending up to the foot. Like
okay.
Examine that it was always present.
Okay. What could be the reasons from the history? What you are expecting?
Some sensory neural, large fiber involvement in the form of posterior column involvement.
Sensory loss you are suspecting, peripheral neuropathy.
Yes, sir.
Okay. What was the fever like? Is the fever also, it was a low grade fever?
Low grade fever, sir.
And cough was of a dry cough?
Dry cough.
Okay. And summarizing, what could be the differential diagnosis?
So basically, it's a multi-system inflammatory disorder is there, which is suggested by a chronic symmetric polyarthritis and multi-organ involvement. So first and foremost, we should suspect our DDs in the form of a multi-system condition. So I would like to incorporate primary vasculitis as my first differential, sir, considering the age and all the symptoms. In that also, like I can give priorities like GPA, granulomatosis, polyangiitis because of the symptoms, and it can be also an eosinophilic granulomatosis, polyangiitis in the background of a bronchial asthma history. The next comes, I'll consider rheumatoid arthritis with vasculitis features also, and last, not but in but included in the differentials, SLE with vasculitis also I would like to consider.
Here anyway, you are pretty sure that patient is having a vasculitis.
Yes, sir.
Can you say that it's which type of vasculitis, or like vasculitis means the inflammation of the vessel walls?
Yes, sir.
The vasculitis can be divided into small vessel vasculitis involving the small vessels, and a large vessel vasculitis involving the large vessels, and the medium vessel vasculitis. In these three groups, which could be in this case, and how will you differentiate? What are the different features of each type of vasculitis?
So I would like to consider small vessel vasculitis in my patient, because in large vessel vasculitis, the symptoms will be like claudication pain, then absence of pulse, then asymmetry in the BP checking, then severe headache, all those things will be there. In the medium vessel vasculitis, they can present with cutaneous ulcers, digital gangrene, ischemia, Raynaud's phenomenon, all these things. In my patient, that history is also not there. But small vessel vasculitis can present in any form, like including, it can involve small nerves also.
What are the typical clinical features of a small vessel vasculitis? For example, I will ask one by one. In skin, what will be the manifestation?
Petechiae, purpura, small rashes, all those.
Rashes, usually palpebral purpura. In eye, what could be the symptoms of a small vessel vasculitis?
They can have conjunctivitis, scleritis, episcleritis, then
uveitis also. Okay. In kidney, what could be the manifestation?
Usually glomerular involvement, sir. So they can have hematuria.
Hematuria may not be macroscopic; it can be microscopic hematuria also. Okay. Lungs.
Lungs, it can have pulmonary nodules, interstitial lung disease,
alveolar hemorrhage.
Alveolar
Pulmonary vasculitis will cause hemoptysis. The symptom will be hemoptysis. Okay. And what about this? Is the arthritis and fever or hypertension, is there a feature of any of these vasculitis, or non-specific?
Medium vessel vasculitis can cause renal artery, so they can present with renovascular hypertension, as in case of PAN and all.
Okay, then I'll ask, what are the common examples of small vessel vasculitis? You're saying that this patient is having scleritis, which is a manifestation of small vessel vasculitis, and patient also has a hearing loss, and you are suspecting more of a small vessel vasculitis. Other things are very non-specific, fever, non-specific, and polyarthritis is also non-specific. It can be seen associated with other connective tissue disorders also. Can you tell me some examples of small vessel vasculitis?
So basically, small vessel vasculitis can be again divided into ANCA-associated vasculitis and immune complex-associated vasculitis.
Before that, it can be again divided into primary and secondary. Secondary means secondary to other connective tissue disorders like rheumatoid arthritis, SLE, or infections. Primary, as you said.
It can be GPA, granulomatosis with polyangiitis, microscopic polyangiitis, EGPA, then renal associated vasculitis, renal limited vasculitis, in that way. Then,
okay, good. And can you tell me some examples of medium vessel vasculitis?
Polyarthritis nodosa, Kawasaki disease, all those things are medium vessel vasculitis, sir.
Okay. Large vessel vasculitis examples?
Takayasu arteritis, giant cell arteritis. Then Beckett's and Cogan's also we can classify in large vessel to some.
Large vessel at this point of time, it is difficult to say because we have not examined the pulse and the BP. Yeah. Therefore, we have to look for the bruit, loss of pulse, and the asymmetry in BP. That all point towards a large vessel vasculitis. Can a small vessel predominant small vessel vasculitis like Wegener's, or you call GPA is the new name, granulomatous polyangiitis, can involve medium vessel also?
Yes, sir. It can
It can involve. The classification is based upon the predominant vessel involvement. That means that in small vessel vasculitis like GPA, the vessel predominantly involved is the small vessel. That doesn't mean that the medium and large vessel cannot be involved. It can be involved rarely.
Okay, sir.
Okay.
So can we move on to the examination
Yes,
part?
yes, please.
So going to the examination, general examination, patient was conscious and alert. Vitals, pulse rate was 122, regular, normal volume, no radiofemoral or radiobrachial delay. All peripheral pulses were felt equally. Blood pressure 110/70 millimeters of Hg in right upper limb and left upper limb in sitting position. Respiratory rate was 18 breaths per minute. Saturation was 98% in room air, and she was febrile 100.3 Fahrenheit at the time of admission. Coming to the height, it was 158, weight was 56, and BMI was 25. And pallor was present, no icterus, clubbing, cyanosis, lymphadenopathy, or edema. And coming to the local examination of the right eye, bilateral subconjunctival congestion was present, which was more on the right eye, along with tenderness and painful restriction of extraocular movement, along with scleral thinning. Left eye was normal. So,
how will you interrupt? How will you check for the tenderness of the, in this case, right eye?
So ask the patient to close the eye. On superficial palpation over the closed eye, they'll be feeling tenderness, sir.
Yeah. Okay, good.
So then,
okay, go ahead.
Then coming to the musculoskeletal examination, inspection, she was examined in supine position. Inspection wise, there is swelling over the PIP joint, third and fourth, but other joints were normal. Then no deformities were noted and gait was also normal. And coming to the palpation, there was tenderness in third and fourth proximal interphalangeal joint, and there is mild swelling also was present in third and fourth PIP joint, and there was no warmth. And all active and passive movements were normal except the third and fourth PIP joint. It was painful flexion was there. There is no restriction or pain on other movements. So then examination of the other systems, I'll be telling only the relevant findings regarding the other systems. Coming to the nervous system examination, higher mental functions, power, reflexes, everything was normal except the cranial nerve 8. Renes was normal and Weber was localized to the right side.
That means?
That is right-sided conductive hearing loss was there.
Okay.
So then coming to the sensory examination, decreased vibration sense was present over both foot. Other sensory signs were normal. So respiratory system, gastrointestinal system and cardiovascular system was normal. So again, after the clinical history and examination, we'll proceed with the summary. A 47-year-old female with past history of bronchial asthma and systemic hypertension presented with complaints of multiple joint pains of 2-year duration aggravated for the past 2 months associated with redness of the right eye, hearing impairment in the right side with sensory neuropathy and low-grade fever and cough of 1 month duration. On examination, she was febrile, she had pallor along with two tender and swollen joints in the third and fourth PAP joint and scleritis of the right eye and right-sided conductive hearing loss.
Dr. Namita, here you're saying that only after exam history it is a polyarthritis, but after examination only 2 joints are active, or only arthritis only 2 joints.
Yes.
Means it's the oligoarthritis.
Yes.
Why the difference?
Because she was
already
started treatment from outside, sir. She already took methotrexate and prednisolone from outside.
Is a treatment modified? Probably she had a more active arthritis before. It was modified by the drugs she is taking. Okay. And you also said there's a scleral thinning. What does that mean?
So when I examine, I can see a bluish hue beneath the sclera. That itself indicates the severity of the disease, sir. We should intervene urgently. Otherwise, she can go into other complications like perforation, all those things.
That also confirms the diagnosis of scleritis. Okay.
So the diagnosis is chronic symmetrical non-deforming episodic polyarthritis.
Here one more thing. What are the causes of deforming arthritis?
It can be rheumatoid arthritis, sir, psoriatic arthritis, osteoarthritis.
Yes. Inflammatory, if you consider inflammatory arthritis only, It's rheumatoid arthritis, it's psoriatic arthritis, and spondyloarthritis. And among the connective tissue disorders, MCTD, mixed connective tissue disorder, can also cause a deformity. But here the history is short. Is sometimes the deformities may happen later.
Okay.
Too early to say that it's a non-deforming disease.
Okay.
Okay.
So basically, chronic symmetrical episodic polyarthritis with ocular involvement in the form of scleritis of right eye, auditory involvement in the form of conductive hearing loss in the right side, with possible sensory neuropathy supported by decreased vibration sense over both feet, along with significant constitutional symptoms like fever and dry cough. So I would like to consider the first differential as a primary systemic vasculitis, especially a granulomatosis with polyangiitis versus eosinophilic granulomatosis with polyangiitis. The second, I would like to consider rheumatoid arthritis with secondary vasculitis, and last, systemic lupus erythematosus with vasculitis, sir.
Can it be infection with a secondary vasculitis?
The history is not favoring, sir. It's a 2-year history, and like that gradual onset, everything is not favoring for an infection.
Arthritis history is 2 years?
She was having joint pains for the last 2 years, but aggravated for the past 2 months.
Okay.
Like aggravated for the past 2 months.
Okay. Otherwise, which type of infection is known to cause vasculitis?
Tuberculosis can cause.
What is the possibility of a paraneoplastic vasculitis here?
That is also, it's a rare possibility considering the age, sir, and
okay,
other system involvement.
Other system involvement, paraneoplastic vasculitis is a entity because one is a malignancy can cause vasculitis, secondary vasculitis. But in this case, history is little long, and the scleritis usually not a common manifestation of paraneoplastic vasculitis.
Okay.
And among the paraneoplastic vasculitis, the most common manifestation is the palpebral purpura or the cutaneous vasculitis. Okay.
Okay.
These are your differential diagnosis.
Yes.
You said the probable granulomatosis with polyangiitis. Do you know the earlier name of the GPA?
Vaginous granulomatosis, sir.
EGPA earlier name? Chuck-Strauss. Okay. How will you confirm or how will you proceed? How will you investigate this patient?
So we have a basic history. We'll move on with the routine blood investigation, including complete hemogram first. So in a patient who is having these multi-system involvement, we should specifically look for anemia, thrombocytosis, CBC, and we can confirm that with peripheral blood smear also, and also liver function test. Liver function test, like multi-system involvement, that they can have transaminitis, they can have hypergamma-globulinemia, hypoalbuminemia, and first part, the other thing was we need to give them treatment. So we need a baseline liver function test before starting the treatment. So all the modalities.
Also the patient is taking methotrexate.
So we need to know any LFT abnormalities are there. And coming to the renal function test, we need to know whether there is any renal involvement, and also urine routine in the form of RBC cast, proteinuria, pus cells, microscopic or macroscopic hematuria. In that form, we need to do all the routine blood investigations along with chest X-ray. If there is any chest X-ray finding suggestive of any pulmonary involvement, I would like to go ahead with CT chest.
What are the common pulmonary manifestations of a vasculitis or vaginous granulomatosis?
They can have diffuse alveolar hemorrhage, pulmonary nodules.
Yes.
These
if you suspect those things in X-ray, you can go ahead and confirm with CT.
Then next, she already had an outside reports of rheumatoid factor positivity, but even though I would like to confirm that rheumatoid factor, we can repeat. And if it is positive, to rule out rheumatoid arthritis, we can send anti-CCP. Then
here comes one of the very important thing in differentials, rheumatoid arthritis. Her rheumatoid factor is positive, that too in a high titer, 120. And she has arthritis. What are the other conditions which can have rheumatoid factor positivity? That is arthritis with rheumatoid factor positivity. What are the conditions which you can see?
Sir, any chronic infections can cause us
First is rheumatoid arthritis.
rheumatoid arthritis. Then
Then
mixed connective tissue disorders.
what are the other autoimmune conditions which can have rheumatoid factor positivity?
SLE, they can have mixed connective tissue disorders.
More commonly, primary Sjogren syndrome.
Okay, sir.
And in vasculitis, in venous granulomatosis, approximately 40% of the patients can have rheumatoid factor positivity.
Okay.
Then, as you said, the infections can cause. And what are the anything else? Like MCTD can also, mixed connective tissue disorder can also. The rheumatoid factor, what you have to understand is a very non-specific test. But as you said, you can confirm it by doing a anti-CCP. Anti-CCP is a more specific marker for rheumatoid arthritis. However, in this case, rheumatoid vasculitis is considered less likely because in rheumatoid vasculitis which occurs secondary to rheumatoid arthritis usually occurs in long-standing, deforming, severe rheumatoid arthritis. Here, the patient is not having much in deformities, and the duration is pretty short. Therefore, I don't consider it as a first differential. It should come in the lower in the differentials. And as you said, rheumatoid factor is positive. Better to confirm it within our lab, and with a better, you can repeat it and do the anti-CCP also. And what else investigations you want to do to confirm your diagnosis?
ANCA, we need to censor anti-neutrophilic cytoplasmic antibody because my first primary differential is like GPA. So we need to confirm that with ANCA diagnosis, or especially C-ANCA. C-ANCA will be positive in 70% case of venous granulomatosis, and then P-ANCA will be positive in 25% of venous. So that C-ANCA, P-ANCA, both we should be sending for this patient, sir.
See here in ANCA, as you said, it's an important investigation in the diagnosing primary systemic vasculitis or ANCA vasculitis. ANCA can be done by two methods. One is immunofluorescence, where you get either P-ANCA or C-ANCA pattern. And if you get a C-ANCA pattern, what is the antigen? What is the antibody you expect?
P-ANCA means it is directed against proteinase 3. P-ANCA means it can be either directed against MPO or other things like lactoferrin, cathepsin. All those things are there. Non-MPO.
Anti-MPO is more specific for the vasculitis. Therefore, if this is positive by immunofluorescence method, that if you get a C-ANCA pattern or a P-ANCA, you should confirm it by doing the specific like anti-PR3 or anti-MPO. Both, according to the ANCA report, you have to do the ELISA method.
Okay.
We can get the titers of anti-PR3. For example, in this case, if you get a C-ANCA positivity, you are expecting a anti-PR3 antibody. Therefore, you have to do a anti-PR3 antibody. If it is positive, it is very specific for venous granulomatosis or GPA. Okay. Okay. Then any other investigation?
Like ANA also we should be doing, sir. SLE also we have considered as a differential diagnosis. So ANA also should be screened.
Okay. ANA if negative, what is the chance of patient having SLE?
2%. Now the entry criteria itself is ANA positivity, sir. So, but 2% of SLE patients can be ANA negative also.
Correct. It is a very sensitive, it's a very high negative predictive value. That means if ANA is negative, we can almost rule out SLE. Okay. Any point in doing complement levels, C3, C4?
Since the patient is not having any renal manifestations, but anyway, we should be.
If urine routine is showing proteinuria or active sediments,
then we should
better to do a C3, C4. Okay. And in this patient, these are your differential diagnosis. For example, if this patient, actually this patient turned out to be anti-PR3 strongly positive. Therefore, it's more in favor of a GPA. And how will you manage this patient or treat?
So basically, the patient presented with severe scleritis. So we should act immediately. So ideally, we should pulse her for first 3 days with higher dose steroids, followed by other treatment regimens like cyclophosphamide or rituximab. Both
Okay.
are showing good response, and followed by, that is induction phase, followed by a remission phase also we should treat. Along
And this vasculitis, primary systemic vasculitis, should be treated, as you said, first with steroids, high dose steroids, along with a steroid sparing agent. Previously, commonly cyclophosphamide was used, and nowadays the rituximab is more preferred because of its less side effects. And in the first phase is called the induction phase, where you control the disease. Then you have to maintain that disease remission on long-term basis. Okay. And here another thing you should know is there are certain conditions which can mimic these vasculitis. Can you tell me some examples of vasculitic mimics?
Yes, sir. In fibromuscular dysplasia, severe atherosclerotic disease, infections like subacute bacterial endocarditis, infective endocarditis, then T-cell lymphoma, all
Yes,
those
as
things
you
can
told, the TB,
TB
vasculitis, and the paraneoplastic vasculitis all can cause.
mimic that. Then certain drugs like levamisole, propylthiouracil, all those things can mimic
Yeah,
vasculitis.
the levamisole actually, it's a cocaine. This levamisole used to adulterate the cocaine. It can cause the venous granulomatosis like presentation. Okay. Okay, Dr. Namita, it's a very good presentation, and the section is open for discussion.
Thank you, sir. Thank you, Namita. We'll now have the question answers. So someone has asked a question. So how can you clinically differentiate SLE and MCTD?
Hi, Subhash.
Hello, sir.
MCTD, both are very closely related disease. Basic MCTD, the classical presentation is puffy fingers, Raynaud's phenomenon, and polyarthritis.
Okay.
That is the classical presentation. And the diagnostic thing is to do a ANA, and if UNRNP is strongly positive, we can consider this as MCTD. However, UNRNP can be also positive in SLE, but usually in SLE, other autoantibodies like dsDNA, SSA antibodies, all will be positive. That means multiple antibodies will be positive in SLE. Whereas in MCTD, along with the classical presentation, there will be usually UNRNP will be only the antibody positive.
Yes, okay.
But many of these MCTD patients can evolve into SLE later also. Therefore, we should, this MCTD diagnosis can change later. We should closely follow these patients.
Okay. So, and one more question was there from the audience. So, how can we clinically differentiate a primary vasculitis from a secondary vasculitis, secondary to infections, malignancies, etc.?
Okay, that we should actually look for the secondary cause. For example, for malignancy, you should always in your history you should ask for the loss of appetite, weight loss, and you should always in the examination you should look for any, if it is female, look for breast malignancy and ask for history of if it's a postmenopausal lady, postmenopausal bleeding, like that. You should search for those malignancies and infections. There is no particular sign or symptom to differentiate primary from a systemic secondary vasculitis, because if vasculitis happened, it will be like a cutaneous vasculitis. It present as a palpable purpura both in primary and secondary vasculitis. Basic thing is that we should look for those secondary causes.
Sir, one more doubt I have is actually, so if a significant weight loss occurs in a patient who is presenting, so that time should we, with vasculitis, so should we consider that can it be a part of secondary vasculitis, or can it also occur in primary vasculitis, so significant weight loss?
Usually in most of our vasculitis, usually they have acute to subacute presentation. A significant weight loss, it also theoretically it can occur, not commonly seen as we see in SLE patients. Usually venous granulomatosis and those things usually present with a acute or subacute presentation. Therefore, there is not much time for a weight loss. We can get 5 to 6 kgs weight loss, not like emaciated patients. If you get an emaciated patient, and vasculitis, consider this tuberculosis, malignancy as a secondary cause, and also SLE, depending upon the age and other criteria. Usually, this is a subacute presentation. That's why weight loss can occur, but not as dramatic as what we see in malignancy, tuberculosis, and SLE.
Sir, one more question, sir. Sorry, sir. This suppose a patient with SLE has generalized significant lymphadenopathy. So can we take that as significant, or should we look for other causes for the lymphadenopathy, or is it just part of the SLE?
SLE can cause generalized lymphadenopathy, but SLE, as you know, it can immunosuppress your body. Therefore, coexisting infections are also common. If you find a significant lymphadenopathy, even if patient is having SLE, other features of SLE, you should ideally biopsy that lymph node. Lymphomas can commonly occur. Tuberculosis can commonly coexist with SLE. Therefore, if there is a significant lymphadenopathy, better to biopsy it.
Sir, so we have one more question from the audience. So what about C3, C4 levels and the renal involvement? What is the significance, sir?
When there is a renal involvement, one second. There will be proteinuria or active urinary sediments. In post-immune diseases, that means if the disease is not mediated by a immune compressed disease, like in vasculitis, it is not immune compressed. It is not an immune compressed mediated disease. Whereas SLE is an immune compressed mediated disease. In an immune compressed mediated disease, there will be complement activation and consumption of the complements. Therefore, the complement levels will be low in an immune compressed mediated disease. Therefore, if C3, C4 low means there's a high chance of an immune compressed mediated disease like SLE. Whereas in post-immune diseases like that means which is not mediated by immune compresses like vasculitis, C3, C4 will be usually normal. And you should remember that SLE is not the only disease which can cause low C3, C4. Post-streptococcus infection can cause low C3. And there are cryoglobic vasculitis can also cause low C3, C4. Therefore, low complement levels means that it is a immune compressed mediated disease. But at the same time, low C3, C4, if it is a mild type of SLE, that the C3, C4 levels can be normal because it all depends upon the how it is consumed. That what is the severity of the activity. Okay.
Okay, sir. There are no more questions in the chat box, sir. Thank you very much, sir. Thank you, sir. And any other comments, sir, from your side, sir?
No. It's actually a multi-system disease. It's actually a challenge. You should, from the history is the most important part. And after the history, you should arrive at a diagnosis. The examination and the investigation is to it should not substitute your clinical history. It's to support your diagnosis.
Thank you very much, sir. Thank you for a valuable time in between the busy times. I know it's very busy schedule, sir. Okay. Thank you very much, sir. Thank you, sir, for enlightening us.
Thank you so
much. Everybody enjoyed the session, sir. Thank you, Namita. Thank you, sir. Thank you very much.